I was one of the doctors in the medical team that treated the Liberian index case of Ebola virus disease, EVD, after he flew to Lagos from Liberia on the 20th of July, 2014. I'm not exactly sure when I came into contact with the virus. It may have been on the night before we ever suspected Ebola when I touched his intravenous fluid bag with my bare right hand and probably touched my eyes, mouth, or nose before I washed my hand. I worked at a private medical center, which was one of the best in Lagos. As soon as we began to suspect that the patient had EVD, we immediately notified the relevant Nigerian authorities. Our patient denied any contact with someone with EVD or attending a funeral ceremony before illness. He had the intention of attending a conference on a different Nigerian state and wanted to be discharged at all costs, even if against medical advice. His condition worsened rapidly with persistent fever, vomiting, diarrhea, and dehydration despite aggressive intravenous hydration. He manifested hemorrhagic symptoms including hematuria, subconjunctival ejections. His breathing was labored, and he was confused. I found him dead on the toilet 5 days after admission. After the possible exposure to Ebola virus, all hospital staff were placed under surveillance. Each person was given a temperature chart and thermometer and asked to measure their body temperature morning and night for 21 days, and instructed to call an Ebola helpline at the first sign of a fever. This was the scariest time of my life. I could not get over my anxiety. I would wake up in the middle of the night to check my temperature. 8 days after my first contact with the index case, and 4 days after he died, I began to feel unwell, with joint and muscle aches. It felt like malaria, so I treated myself with anti-malarials. 2 days after the onset of symptoms, I developed a fever. My sore throat progressed gradually. I quickly developed a loss of appetite, and I felt absent from my environment. I noted every sign and symptom, but did not realize how quickly they had progressed. It did not initially register in my head that I had EVD. Like many people, I was in denial at first. Nobody wants to be diagnosed with EVD. Even many educated patients do not believe they have the disease until the confirmatory test is received. We often choose to believe it is some other disease that we can handle, certainly not one with a mortality rate of up to 90%. On the second day of fever, I called the Ebola helpline and an ambulance came for me within a few hours. Blood samples were taken, the EVD result was positive, and I was taken into isolation. This result was devastating. The constant news about Ebola on television and radio was not helping matters at all. The first person I met when I got into isolation ward was a World Health Organization WHO doctor, Dr. David Major. He was the only doctor at the time, and he came to see us at least twice daily, shuttling between the male and female wards. He helped out with cleaning it up as well, because the nurses were too scared to enter the ward. He told me that 90% of my response to the infection was dependent on me. There was no specific antiviral treatment, only supportive therapy. The major concern was treating and preventing dehydration from fluid loss. Dr. Brett Major helped mix my first bottle of oral rehydration solution, ORS, and challenged me to drink at least 4.5 liters of the fluid daily. He would spend time chatting with us individually, and I could tell he was a cheerful person, even though the only part of his face I could see was his eyes through his misty goggles. I was impressed and touched that he came all the way from Geneva to care for us. Soon after, volunteer doctors started to show up at the ward, running about 3 shifts daily, I recognized some of them, and it made me comfortable being in the hands of people I knew and had worked with. They knew we were lonely, understood our fears, and always tried to put smiles on our faces. The heat was overwhelming. I couldn't imagine wearing the personal protective equipment, PPE, for more than 5 minutes. Emergency care was not at its best because it took a long time for the doctors to put on fresh PPE and get into the ward to see the patient. If a patient was on intravenous fluids, somebody was needed to ensure that a new bag of fluid was hung. Because we were short staffed, I did most of the work managing intravenous lines for critical patients who could not consume ORS. Notable among the volunteer doctors was one of my consultants during internship at the Lagos University Teaching Hospital and a resident doctor I had worked with. I remain grateful to these heroes for going where so few dared to go, putting their lives at risk to help save us. Some volunteers ran away after a few days. I understand. It could not have been easy staring death in the face. There were others who volunteered to work in the ward, showed up, but evaded the responsibility conferred on them to help the sick. They would be around, but would not respond when called by patients. I was kept in a room that stank of depression. Indeed, depression had become the order of the day in the ward, with patients suddenly crying out of frustration. There was no form of entertainment. We had so many unanswered questions. Were we going to survive? How long would we be in the ward? Why did some of us seem to get better, only to suddenly deteriorate and succumb to the infection? Who exactly were our caregivers all covered up in masks and suits? I felt like I was a dangerous alien from whom people needed protection. I battled for my life while watching patients die one by one next to me. Was it my turn? I could not accept that. The fever was weakening me. The constant diarrhea was degrading enough to make me wear adult diapers. The vomitus was so bitter that it made me want to vomit even more. Sleeping was so difficult because no position was good enough for my severely aching joints. There was a heaviness in my chest that made it hard to breathe. I woke up most mornings to sharp pains in my eyes from the sunlight, my first experience with photophobia. My body was soon covered with red spots, particularly my arms and legs. We EVD patients all noticed that we were urinating more than usual. I woke up several times a night to pass urine, which was foamy and concentrated. I knew it was not a result of the many bottles of ORS that I consumed because I still felt dehydrated and my throat felt dry. This phenomenon reduced as my symptoms subsided. I observed that some of my fellow patients had a zombie look, very aloof and a little scary, as though they were not present in their bodies. The only treatment I received were bottles of ORS, paracetamol, and vitamin supplements. I drank like my life depended on it. I prayed to God like my life depended on it. 5 days after my admission, when I thought I could take no more, the vomiting started to subside. I ate a lot of bananas because I suspected my potassium level was low. Soon after, the diarrhea stopped and the fever subsided, only to return later due apparently to a malarial infection from the legion of mosquitoes that shared the room with us. Based on only a hunch, because routine malaria testing was not performed as a result of safety concerns, I decided to self-treat for malaria. The fever was gone on the second day of treatment. I was discharged 14 days after I was admitted, after blood tests for Ebola virus came back negative. That gave other patients hope that they would one day leave the ward too. Recovery has been gradual but progressive. My appetite returned to what it was like pre-EVD after 6 weeks. Fatigue lingered on for months, but gradually improved. I lost about 2/3 of my lovely hair and had to shave it all. I struggled I struggled with fleeting joint pains for months. The joints would suddenly become painful and swollen. After a few days, the pain would disappear, only to reappear in another joint days later. Now, 3.5 months after leaving isolation, I feel much better and am ready to pick up where I left off. Fortunately, the swift response from the Lagos Ministry of Health to contain the outbreak was successful. I have learned that with the right strategies, tools, and resources, we can stop this epidemic. Containing an outbreak is a collective effort. Every arm of government must be involved to mobilize all resources available to fight our common enemy. When a case is confirmed, the government must act swiftly to stop the chain of transmission. The right information must be disseminated to control fear and panic and prevent stigmatization. Some traditional rulers informed their people that the consumption of salt and water at certain times of day would help prevent and cure EVD. This, unfortunately, led to the death of a number of people who diligently adhered to their advice. What have I learned from my experience with EVD? First, volunteer healthcare workers treating EVD patients, in addition to administering drugs, should understand that a smile, a handshake, and words of encouragement greatly help to lift the spirits of the patient. Second, hope is necessary for survival. Videos of interviews with survivors should or would be valuable, teaching patients that their diagnosis is not a death sentence. Third, the health workers needed to take short shifts because it was difficult staying in the PPE for more than 30 minutes. A fatigued healthcare worker is a risk to the patient, to him or herself, and to the public. Thus, caring for EVD patients requires a great deal of manpower to appropriately manage complex patients and avoid the fatigue that can lead to breaches in protocol and possible healthcare worker infection. I remember the ones we lost in this battle against Ebola. My mentor, Dr. Adedova, the consultant physician who did not let the index case leave the hospital despite threats. Nurse Justina Agelonu, who contracted the virus on her first day of work while tending to the index case. And the other brave men and women who paid the ultimate price to save others. They are the real heroes we can never forget. It is my hope that we see ourselves as connected to each other. The world is a global village, and we must be our brother's keepers. Let us work together to fight and conquer Ebola. Hello, everyone, and welcome. My name is Dr. Jeremy. I'm the everyday epidemiologist. That harrowing story that we just heard was the first-hand account given by Adora Igonoh after she became infected with Ebola in 2014. I read through that story multiple times, and every single time it got to me, especially at the end when talking about those that died. Such an incredible story. Thank you, Adora, for sharing your experience. Today, obviously, we are going to talk about Ebola. Now, I personally find this one of the coolest diseases. It totally fascinates me. It is horrifying and terrifying, yes, but it is also really cool. It is one of the diseases that made me want to get into epidemiology. But before we get into all of that, a few quick disclaimers. First, I am not a medical doctor. Nothing in this video is medical advice. Any medical advice you want or need should be obtained from your physician. Second, this information is being brought to you by me alone as someone who knows a bit about public health. It is not coming in any sort of official capacity from the health department where I work. Third, all the information provided in this video comes from publicly accessible websites, books, and research articles. The sources are in the description of the video. Fourth, I try to provide as accurate and scientifically based information as possible. However, I may misspeak or say something that is incorrect unintentionally. If you catch me on this, please leave a comment with what I said wrong and if possible a source to the correct information and I'll look into it. If I was wrong, I will provide the correct information in a future video. There may be some pictures of sick people in the presentation. I will try to warn you beforehand, but I may miss it, and I apologize for the pictures earlier on that I did not warn you about. So if you're squeamish, sorry, and I'll try to warn you. Lastly, I will stop for questions periodically throughout the stream. However, feel free to type any questions you have in the chat at any point, and I will answer them as I see them. If you are watching the VOD later, please leave your questions in the comments, and I'll answer them as soon as I can. So without further ado, let's talk about Ebola. Ebola symptoms show up after an incubation period of about 2 to 21 days. But on average, they appear 8 to 10 days after infection. These symptoms usually start with a sudden fever, headache, fatigue, muscle pain, and a sore throat. These are known as the dry symptoms and are obviously pretty generic. They are oftentimes thought to be symptoms of malaria, flu, typhoid fever, or some other disease. About 4 to 5 days after these symptoms start, infected people can progress to wet symptoms as they become sicker. These include loss of appetite, unexplained bleeding, and gastrointestinal symptoms such as nausea, abdominal pain, diarrhea, and vomiting. The bleeding can be internal or external. This includes blood and vomit, feces, bleeding from the nose, gums, or vagina. Bleeding where the skin has been punctured by needles also can occur. Patients with severe disease can also show symptoms of impaired kidney or liver function. Other symptoms may include chest pain, shortness of breath, eye redness, skin rash, hiccups, and seizure. The virus can also affect the central nervous system, resulting in confusion, irritability, and aggression. As I'm sure most of you are aware, Ebola is a very deadly disease. The mortality rates of Ebola vary between the different strains of the virus. We will talk more about the strains a bit later on, but I'll give you the mortality rates here. Ebola Zaire has the highest mortality rate of between 60% and 90% depending on the outbreak. That is followed by Ebola Sudan. That is followed by Ebola Sudan at between 40 and 60%. Ebola, all right, I'm going to try to say this right the first time, but we'll see. Ebola Bundibugyo, I think that's how it's pronounced, has only one known outbreak with an estimated mortality rate between 25 and 35%. Ebola Thai forest has only been observed in one person, and that person survived. And finally, Ebola Reston does not cause illness or death in humans. People who die from Ebola virus are usually the ones that develop the more severe symptoms early in the illness. Patients who survive may have a fever for several days, then begin improving about 6 days after symptoms appear. Despite the typical perception that bleeding is one of the more common symptoms, it actually is not all that common or typical. When it does happen, it typically occurs later in the disease progression and only in those that have more severe disease. So, with all that nastiness out of the way, I'll stop for a quick break to see if there are any questions at this point. I know we haven't covered much about Ebola, but the story did cover a lot, so you all may have some questions. So I will take those and see what you might be interested in knowing at this point. So feel free to type in any questions you may have in the chat at this point. And if you don't have any questions at this point, that is fine. You can ask them at any point later. Well, I'm not seeing any questions at this point, so let's go ahead and move on. Now let's talk about the pathogen. What causes this nasty disease? Ebola is caused by a group of viruses called the ortho-Ebola viruses. There are 6 known ortho-Ebola viruses that we know of. 4 cause disease in people. Ortho-Ebola virus Zaire, known as Ebola virus. Ortho-Ebola virus Sudan, or the Sudan virus. Ortho-Ebola virus Tiansi, or Thai forest virus. Ortho-Ebola virus Bundibugyo something like that, or the Bundibugyo virus. Those are the 4 that are known to cause disease in people. 1, ortho-Ebola virus Restonensi, or the Reston virus, does not appear to cause disease in humans, but does cause disease in other primates. The last one, ortho-Ebola virus Bombaliense, or the Bombali virus, doesn't seem to show disease in people that we know of, or animals. It has been detected in bats, but that's about all we know about it at this point. It has not been shown to cause any disease, but we just don't know very much about it. But what are ortho-Ebola viruses? They are elongated filamentous viruses of variable length. They can take several shapes. They can be branched, circular, or U-shaped. Though the shape you typically see is this curved shape that you see on screen that kind of looks like a kind of messed up shepherd's hook. These viruses belong to a larger virus family that includes the viruses that cause other horrible diseases like Marburg and Lovio, which is a deadly disease in bats. So, where did this virus come from and how does it spread? It is thought that fruit bats are the natural host for the virus, meaning this is where the virus normally lives and circulates. Viruses and other pathogens often don't cause disease in their natural host. However, we don't know exactly how this virus is transmitted and maintained in the bat population. Sometimes, other animals come into contact with an infected bat or the bodily fluid from an infected bat. If they have close contact with the blood, secretions, or other bodily fluids or organs, they can become exposed and potentially infected by the virus. Chimpanzees, gorillas, monkeys, forest antelopes, and porcupines have all been found to be infected with ortho-Ebola viruses. If a person comes into contact with an infected animal, like through gathering or preparing bushmeat, they can become infected as well. Human-to-human transmission occurs through direct contact with bodily fluids or objects contaminated by infected bodily fluids. People at highest risk for human transmission are healthcare providers and family members caring for someone with Ebola virus disease. Others at high risk are those who prepare the bodies of those who have died and mourners at the funeral. In many areas of Africa where Ebola is present, funeral services include touching the deceased. If that person died due to Ebola, those people are at risk for catching the virus. This is because the infectivity is highest when a person is the most sick, and those that are the most sick are those that die. This is different than many illnesses. Take COVID or the flu, for instance. With those diseases, you are most effective shortly before and shortly after symptoms appear. As your symptoms get worse, typically your infectivity decreases. This is not the case with Ebola. It just keeps ramping up as your symptoms get worse. Sometimes the virus can persist in people even after they recover from the disease. This is particularly the case in semen, where the virus can be isolated up to 82 days after the symptom onset and detection of the virus. 82 days after the symptom onset. There we go. Detection of the viral RNA can happen up to 406 days after the symptom onset. While live virus has never been isolated from vaginal fluid, the viral RNA has been detected there up to 33 days after the onset of symptom. So far, there has been one example that we know of likely sexual transmission of Ebola. In 2015, a woman in Liberia tested positive for Ebola virus after having unprotected sex with an Ebola survivor 2 weeks earlier. The man had symptom onset back in September 2014 and obviously later recovered. After the woman tested positive, the man's blood was tested for Ebola and came back negative. Then they tested his semen, and it came back positive. While it is apparent that this can happen, it does seem to be rare. Overall, the likelihood of sexual transmission is unknown, but it is likely uncommon. So, how is Ebola treated? The major treatments for Ebola are optimized supportive care. This includes pain management, nutrition and hydration, limiting and treating co-infections such as malaria, and medication to deal with the symptoms, including blood pressure medication and those to reduce vomiting and diarrhea. On top of that, there are 2 medications that are currently available for use in patients infected with orthoebolavirus syrensis. These are Enmazeb and Banga. Both are monoclonal antibodies that can attack the virus. There are no approved treatments for any other Ebola virus, any other diseases caused by any of the other Ebola viruses. However, there are several that are in development, so hopefully they will be successful in clinical trials and become approved soon. Now, before we get into any prevention or public health of Ebola, I want to take a few minutes and talk about the history and some of the outbreaks that have happened. First, I want to mention location. Most Ebola has occurred in Africa with limited human cases in Europe, Russia, and the United States. All of these cases outside of Africa were either laboratory cases where the disease was brought back from Africa. There have also been some monkeys infected with Ebola in the Philippines and bats in Bangladesh. So, the first time Ebola was identified was during an outbreak in the Democratic Republic of the Congo in 1976. The index patient, meaning the first patient known to be infected, was treated at a local hospital. The hospital thought he had malaria and injected him with malaria treatment. Unfortunately, he did not have malaria. Transmission continued through the use of contaminated needles and syringes at the hospital and clinics, as well as through close contact, where there was inadequate use of personal protective equipment. In this outbreak of Ebola Zaire, there were 318 confirmed cases. 280, or 88% of them, died. Later that year, the first outbreak of Ebola Sudan was identified in, you guessed it, Sudan. The outbreak was believed to have started with workers at a cotton factory. 37% of the workers there had become infected. In total, there ended up being 284 cases and 151 deaths, as a mortality rate of 53%. Over the next couple of years, there were several small outbreaks of between 1 and 34 cases each. All except for one occurred in Africa. That one was a laboratory exposure in the United Kingdom. Then, something very odd happened in 1989. In November 1989, a monkey quarantine facility in Reston, Virginia, the United States, which is about 22 miles west of Washington, D.C., noticed an unusually large number of deaths and a new shipment of monkeys. The veterinarians on staff conducted necropsies of the monkeys and determined or suspected that it was simian hemorrhagic fever that caused these deaths. This is a very nasty disease in monkeys, but doesn't affect humans at all. To confirm this, several monkeys were shipped up to Maryland to the United States Medical Research Institute of Infectious Diseases. The scientists there are trained to work with some of the worst pathogens in a safe way. What they found was not simian hemorrhagic fever, and was much, much scarier. They found that these monkeys died from Ebola. That's right, Ebola was in the United States, and not far from the capital or two major airports in the area. Despite the best efforts of the workers at the quarantine facility, the disease spread somehow to another room and started killing monkeys there. To try to prevent the spread of the virus or to prevent it from getting out, they ended up euthanizing the remaining 500 monkeys in the facility. Blood tests were performed on the 178 people who had or potentially had come in contact with infected monkeys. 6 tested positive for Ebola antibodies, indicating that they had been infected. But luckily, nobody got sick. It was very fortunate that this particular virus does not affect people. Recent geospatial analysis indicated that if this virus could have affected people and could have spread in people, it would have very easily spread throughout the area and would have likely quickly reached the airports. This is how the Ebola Reston virus was discovered. The book The Hot Zone, The Terrifying True Story of the Origins of Ebola Virus by Richard Preston is about this incident. It is a fantastic book, and I highly recommend you check it out. Between 1989 and 2008, there were 5 other Ebola Reston viruses in the Philippines, Italy, and the United States. The first, and to date only, outbreak of Ebola virus TNCs occurred in Côte d'Ivoire, the Ivory Coast. Sorry, I can't pronounce that very well. In 1994. In this outbreak, one person became infected while conducting a necropsy on dead wild chimpanzees. The patient was treated in Switzerland and later recovered. In 2007, an outbreak of Ebola occurred in the Bundibugyo virus district of Uganda. This was a novel strain of Ebola called orthoebola virus Bundibugiense. There were 131 infected people with 42 deaths for a mortality rate of 32%. In 2014, things got very, very bad. In December 2013, an 18-month-old baby boy in southern Guinea came in contact with bats and became infected with Ebola Zaire. From there, it spread throughout southern Guinea, reaching the nation's capital in March of 2014. On March 23rd, the WHO officially declared the outbreak. At that time, there were 49 confirmed cases and 29 deaths. Cases were soon discovered in Liberia and Sierra Leone, to nations that border Guinea. The identification of cases was difficult due to fragile public health infrastructure and weak surveillance. Poor infection control measures and overly strained healthcare systems, along with poor surveillance, allowed the outbreak to grow rapidly. Between June and September 2014, the number of cases was doubling every 16 to 30 days. In August, the WHO declared the situation a public health emergency of an international concern. Aid workers from the WHO, the US CDC, and national and international partners were sent to these three countries to assist with the treatment of the sick, the prevention of additional cases, and surveillance and identification of new cases. As sometimes happens, some of these aid workers became infected themselves. Some of them were brought back to their country of origin for treatment, bringing the virus with them. One healthcare volunteer from Italy became infected while working in a treatment unit in Sierra Leone. This individual returned to Italy not knowing that they were infected. 72 hours after arriving in Rome, they developed symptoms. Luckily, it did not transmit past this person, and that individual recovered. Spain experienced the first ever human-to-human transmission of Ebola virus outside of Africa. A healthcare worker became infected while treating a patient evacuated from Sierra Leone. While the patient later died, the healthcare worker did recover. In a case similar to what happened in Italy, a healthcare worker returned to the UK and developed symptoms upon arrival. They recovered and no additional cases were identified. 11 people were treated for Ebola in the United States. 2 of these individuals started showing symptoms after returning from Africa, while 2 were infected in the US while treating a patient. One of the 4 people who got sick in the United States died, as did one of the others that was brought back for treatment. In addition to all of this, in addition to all of this, people brought Ebola virus to other African countries. An infected traveler brought the virus to Mali, resulting in 8 cases and 6 deaths. Another brought it to Nigeria, resulting in 20 cases and 8 deaths. One of those cases is the one that we heard about earlier. Yet another infected traveler brought the virus to Senegal. However, this person did not infect anyone else and later recovered. While all of these other countries were affected by the outbreak, it pales in comparison to what happened in Guinea, Sierra Leone, and Liberia. Combined, these 3 countries had 28,610 cases and 11,308 deaths. This is a mortality rate of 39%. While that is horrible, it is actually quite lucky. The Ebola Zaire virus can have and has had up to a 90% mortality rate. So it could have been much worse. This is by far the largest Ebola outbreak to date by number of cases and deaths, as well as being the most widespread in the number of countries and regions of the world affected. The outbreak was declared over in June 2016. 2018 saw another large outbreak of Ebola Zaire in the Democratic Republic of the Congo. This outbreak resulted in 3,470 cases and 2,287 deaths, for a mortality rate of 66%. So, as I said, the 39% in the 2014 outbreak was quite lucky. Last year in 2025, there were 2 Ebola outbreaks. There was an Ebola Zaire outbreak in the DRC that affected 64 and killed 45 people. An Ebola Sudan outbreak in Uganda affected 12 and killed 4. There have been 9 Ebola outbreaks since the start of 2020. In total, from the first identified case through today, as of the date of this live stream, there have been 47 identified outbreaks affecting 35,023 people, with 15,456 people dying due to this disease. That is a 44.1 that is 44.1% of people infected with Ebola dying from this disease that we know of. Numbers of cases and deaths are both likely higher than this. But now let's take a short break to see if there are any questions at this point. So feel free to type any questions you have about Ebola, and I will try to answer them. Well, again, not seeing any questions at this point, but if you have any at any point, let me know. But how do we stop from getting infected? What methods are used to prevent transmission? And what does public health do to both prevent and respond to Ebola outbreaks? By far, the best form and main form of prevention is avoiding contact with bodily fluids from infected or potentially infected people and animals. These bodily fluids include urine, feces, saliva, sweat, vomit, breast milk, amniotic fluid, semen, and vaginal fluid. All of these are known to or inspected or suspected of containing the virus and should be avoided. If they need to be interacted with, proper personal protective equipment, PPE, should be used. In addition, clothing, bedding, needles, medical equipment, and other items that may have touched an infected person's blood or bodily fluids should be avoided or handled with proper PPE. Safe funeral practices. There is a picture of a funeral of a dead person on screen. Sorry, I meant to warn you about that. I apologize. But safe funeral practices where the body of someone who died from Ebola should be performed. This means that the body should not be touched as part of the funeral proceedings. Lastly, bodily fluids and raw meat from bats, forest antelopes, primates, and unknown animals should be avoided or handled with proper PPE. Importantly, meat of an infected or potentially infected animal that has been cooked is safe and can no longer transmit the virus. The picture of the funeral services is off the screen now. What sort of PPE should be used when interacting with someone with Ebola or a potentially infected fluid or object? Well, that's really kind of complicated because it really depends on exactly what you're doing. Additionally, most people watching this video don't really need to know about those, and those that do need to know, no. So I won't go into the full details, but basically it includes wearing gloves, including multiple layers of gloves, especially the top layer needs to be a thick, durable glove. Masks, typically including a full face covering or a full hood, and water-resistant, waterproof coveralls and boots. And sometimes, depending on exactly what you're doing, respirator. But as I said, it really depends on exactly what you're doing. So what all you're wearing can vary a little bit. Now, that being said, prevention is great and all, but obviously people still get infected and get sick. So how do epidemiologists, healthcare workers, other public health workers, and governments respond when this happens? And that is a great question. Thank you for asking. Let's get into that now. The investigation always starts with identification of one individual with the disease. Immediately after that, emergency response is activated. Epidemiologists conduct interviews to determine how and where this person became infected and who may have been exposed to them. Then we try to identify other cases and understand the extent to which the disease has spread already. From there, infected people are isolated and treated while exposed individuals are monitored for symptoms. If they become symptomatic, they are isolated and treated as well. In Ebola Zaire outbreaks, the only existing Ebola vaccine, Ervebo, is used. I think I have a picture of that. Yeah, there we go. It is used in what is called ring vaccination. This is where people surrounding the infected cases are vaccinated to try to prevent the spread. In the case of the 2014 to 2016 outbreak, it was shown to reduce Ebola disease rates starting 10 days after the beginning of the vaccination. In addition, education campaigns are started to share the methods and risks of exposure and methods of reducing the chance of exposure. Situation reports and maps. May I have a picture of that? No, I don't think I do. Situation reports and maps are generated throughout the outbreak to share information and track the progression of the outbreak. Once there are no more sick people, we continue working and monitoring the area for additional cases. We don't consider the outbreak ended until it has been 42 days since the last confirmed person with Ebola tested negative for the virus or dies. This is twice the upper limit of the incubation period. Despite the outbreak being declared over, people working in public health, especially in areas where Ebola pops up, maintain surveillance to rapidly identify and respond to any reemergence or any new outbreaks. So, that in a nutshell is Ebola. That's the symptoms, the spread, history, treatment, and prevention. So now I will stop again to take any more questions you may have about this horrible, terrifying, but in my opinion, pretty cool disease. So let me know if you have any questions at this point. So luckily, there have not been any Ebola outbreaks this year. But for those of you who may have watched my 2026 public health bingo card, I predicted that there might be an Ebola outbreak this year. So we'll see if that comes true or not. Not every year does experience Ebola outbreaks. Probably a majority of those do, especially in recent years. Part of that is due to increased surveillance and increased or improved method or ability to detect the disease and respond to it, and also potentially due to increase in human population spread into the jungle and the forested areas where Ebola is present. So it may happen, may not. I hope it doesn't happen. But we will see if it happens in the next 9.5 months. But I'm not seeing any questions at this point. So just a reminder that if you're watching later, or if you think of any questions later, feel free to put them in the comments, and I will try to respond to them as soon as possible. So I want to thank you all for joining me today as we talk about Ebola virus, and I hope you enjoyed it. I hope you learned something. And Yeah, I hope you find Ebola as interesting as I do. I hope I didn't scare anyone too much with Ebola. It isn't something that most people need to worry about. Um, m- Most people, even in countries where Ebola is present, don't really need to worry about Ebola too much. But those that do live in the area, especially those that are healthcare workers or survive or use and eat bushmeat and might be exposed to the bodily fluids of the potentially infected animals that I listed earlier, do need to watch out for it. They do need to be careful. Um, and as long as you take the effective precautionary measures and limit your exposure as much as possible, that will help prevent you from becoming infected with this horrible virus. Um, so yeah, thank you all for being here. I'll be back in a couple of weeks with another episode. Not sure what it will be yet, but I hope to see you all there. Um, so I want to remind you all that I do share public health updates and public health news, both here on YouTube and over on Bluesky on a regular basis. So be sure to check those out. So stay healthy, stay happy, and remember, public health is for the good of everyone. Take care, everyone. Bye.